Hello, everyone. Welcome on behalf of the Mid-Atlantic Public Health Training Center to our September Public Health Practice Grand Rounds. My name is Janie Gordon, and I want to welcome everyone who is both live in the audience and watching us via webcast. Today, our Grand Rounds will be on making the Affordable Care Act work, promoting young adult participation, and primary care. I have a few announcements before we get started. For people who are watching online, please check out our archived Grand Rounds and other online trainings. Also, please check the MAPHTC events calendar for our fall training schedule. Right now, we have two in-person trainings that are open for registration. One is October 1st, Achieving Outcomes through Best Process Program Design and Evaluation, and that will be in Harford County. And the second is October 4th, Effective Writing, and that will be in Howard County. Our next Grand Rounds will be October 16th and will address determinants influencing willingness to respond in public health emergencies and innovative community emergency response programs. For those watching online, you can email a question for today's presenters by simply clicking on the link, or you can send your email to maphtc@jhsph.edu. With that, we're ready for today's presentation, Making the Affordable Care Act Work, Promoting Young Adult Participation and Primary Care. And I'd like to introduce today's speakers. And before I do that, I'd like to say our second speaker is on her way. I believe from the last text I have, she is coming from the parking garage. So hopefully she'll make it here and be able to join us. But I'll introduce both speakers anyway. Our first speaker is Pat Cassatt. Ms. Cassatt is currently the CEO of People's Community Health Centers, which operates 8 clinics in Baltimore City and Anne Arundel County, providing full-service primary medical care, as well as dental care, substance abuse treatment, and mental health care, regardless of patients' income or insurance status. Ms. Cassatt has over 27 years of experience in nonprofit management and 10 years experience in corporate America. Prior to her tenure at People's Community Health Centers, she held positions of executive director of a faith-based mental health program and assistant director of a mental health addiction program and a women's shelter for domestic violence. She began her clinical career as a speech pathologist and audiologist, duly credentialed in speech language and behavioral sciences. She devoted the early part of her career to the clinical care of trauma victims. Later, she received a graduate degree in business from the University of Baltimore and a Master of Science degree from Loyola College. Ms. Cassatt achieved and retained certification as a registered lobbyist for 10 years and has worked on consumer advocacy issues regarding education and health care. She guest lectures at several local universities on the issues of the uninsured and public policy, and she has served as a commissioner for the Anne Arundel County HIV/AIDS Commission since April 2009 and has served since 2012 on the Local Health Improvement Coalition for the county. And we're very happy that she took time out from her schedule to be with us here today. Our second speaker, Amy Lynn, is the Deputy Policy and Organizing Director at Young Invincibles. I just love the name of that organization, where she leads the organizing team on outreach on healthcare, education, and jobs campaigns across the country. She began her tenure at Young Invincibles leading the National Youth Bus Tour, a 3-month-long national listening tour. Ms. Lynn was previously staff and legislative assistant for Senator Edward M. Kennedy in the Labor Policy Office on the Senate Help Committee. For Senator Kennedy, she worked on labor issues, including unemployment insurance, the economy and jobs, the right to form a union, paid sick days, and the Lilly Ledbetter Fair Pay Act. She served as the staff assistant for the chief economist at the U.S. Chamber of Commerce and development coordinator at the Institute for Women's Policy Research, a nonprofit think tank focused on policy issues that affect women. Ms. Lynn has a BA in Economics from Tulane University and a Master in Public Affairs from the Woodrow Wilson School of Public Health and International Affairs at Princeton University. And I think I may see her in the audience, so I'll go and get her while Ms. Cassatt begins. Thank you.
Good afternoon. Thank you for inviting me here today. I appreciate the opportunity to speak about something that's near and dear and is changing very rapidly. So I was asked to speak about primary care in particular, and that will be my area of focus for this afternoon. I was informed that the group has been keeping up on healthcare reform up to about 6 or 8 months ago, and that there have not been any updates, at least in this forum, for the last 6 or 8 months. So I am going to start there with some of the reforms that have happened within the last 6 or 8 months, some that are on the drawing board that will be soon rolled out, and that will give a context for the response that a primary care center such as ours needs to be prepared for and able to respond to. So I'm going to start with insurance reforms. The essential health benefits have been declared by the state of Maryland. There are 10 that the federal government required, and on the left side of the column, you'll see what the 10 requirements are for insurance companies that are entering the exchange to sell as a qualified health plan. The plans offered through the Maryland Health Connection, which is the name selected for Maryland's version of healthcare reform, will include medical-only plans, medical plans embedded with dental, and standalone dental plans. So you may see there that there is nothing mentioned about behavioral health, and that is because simultaneously with this reform, the state has decided to reform its mental health community, and they are including substance abuse now with mental health, which has not been the case before. They were considered completely separate, and they are being consolidated under a whole different payment stream and regulatory body. So they will remain outside of the exchange. The authorized carriers that have been approved, and this is very recent, for selling on the exchange are on the medical side. You will see 6 listed. Evergreen is our only co-op in the state of Maryland, awarded a separate loan and grant by the federal government. And Coventry has been removed by its parent company at this point in time. The standalone dental, as you see, is a much larger group of companies that have been able to enter the exchange and sell. Regarding the uninsured, which is the population of focus that we have dealt with for many years, this group of people who will be newly purchasing, they hope, on the exchange amounts to a little over 100,000 people. And of those, most of them will be eligible for the tax credits that will help them pay their premiums. And therefore, the federal government will be providing subsidies for premium payments for all of these new entrants into the marketplace. In addition, there are people that are currently insured by their employers, and their income levels are such that they too will qualify for tax credits. So they're anticipating that there are about 58,000 individuals who currently have insurance that will shift from their current insurance carrier and purchase through the health benefit exchange. This gives you an idea of the federal poverty levels and what that means in annual income and what the burden will be on a monthly basis for paying for an insurance premium on the exchange. And again, these are the uninsured, and this is the population that most community health centers are funded to serve, and it's their mission to serve them. You will see that as the income levels grow, the percentage of their income that must be devoted to insurance premiums grow, And for the first several years, the only option is for a person to pay an annual penalty. Right now, the annual penalty is $95 for the year, and many people will opt for that $95 for as long as they can, rather than incur these monthly fees. One recent change in the reform has come from Washington, and that is the removal of the out-of-pocket limits. And that's been an issue that will further exacerbate this particular situation, because for someone to buy insurance and have no understanding of what their out-of-pocket expense can be on top of their premium payments, it will make it much more, well, the individuals will be much more cautious jumping into a financial obligation like that. Co-pays for all visits and for prescription drugs are a barrier now, even with the insured population, and they'll be a barrier for this group as well. This is the projected new enrollment once things launch in January, and you'll notice that there are a lot of TV ads right now for Maryland Connection, because in October 1, our state will be one of the few states that are ready to start enrolling people, even though their benefits won't become effective until January. So most of the expansion is expected in the Medicaid side of the house rather than the Health Connection, the exchange, and that's because of the income levels that they are aware of the uninsured right now. The 138% of poverty seems to have the most individuals clustered right now. The other thing that's changed in the last 6 months is that the Navigator entities have been selected. There are 6 jurisdictions in the state of Maryland that were declared by the governor, and those were each awarded one Navigator, and they were awarded different Navigator companies. So what you see here is a little bit of an interesting new role for some of the local health departments, because 2 of them applied to be Navigators, and they were awarded those positions. So Healthcare Access Maryland has probably the largest population and a large geography. SEEDCO has the Upper Eastern Shore, Worcester County Health Department has Lower Shore, Montgomery County Health Department has Montgomery and Prince George's. Calvert Health Solutions is a company that's serving Southern Maryland, and Healthy Howard took the entire western region from Howard County and west. Interesting other aspect to healthcare reform is the accessibility. Individuals will be able to apply online and by phone or mail or continue at their DSS offices. Community health centers have recently received an award nationally to have their own application counselors on staff, so every health center will be an access point for enrollment. The state also recently had to undergo a testing process. The federal government had to declare the state as really prepared to enter the exchange and manage its own process, its own version of healthcare reform. So there's been a superhighway built, an electronic superhighway that connects our databases here in Maryland to the IRS database, to the Social Security Administration database, and other federal data repositories, so that when someone applies online, or we and our staff apply on their behalf, it will be similar to applying for a credit card with that instant notification that you get right away. So the individual will know, are they eligible for Medicaid, or does their income and asset place them in a position where they have to purchase through the exchange? So our state passed. Our state was involved in some very intensive testing, and they passed on all fronts, so we've been given the green light to go ahead by the federal government. Not all states are in that situation. Some have had to delay their launch, so we're very much in the forefront. So again, this out-of-pocket limit delay, and there's another delay that I did not mention, and that is that the employer mandate was delayed for a year. And a lot of low-income people will opt to pay that penalty rather than to jump into this financial obligation. And those who choose a low metal plan, and those of you who've been following it know that the plans are named after precious metals, bronze, silver, and platinum, and so on. And if they do take this choice of not having coverage, then the clinical outcomes of themselves, their family, will be impacted because their treatment adherence and their medication regimen, all of that will be impacted, which impacts their health care outcomes. And a little bit later, when I talk about provider reforms, you'll understand why that's important in a primary care setting, and especially a safety net setting that attracts a lot of individuals who will not have the resources to obtain their treatment. There's also an interesting phenomenon called crowd out, and it's already started. And that's where companies tend to look for the ways to save and not be impacted by the new federal regulation that's coming down the pike. And IBM and UPS have all taken a position of either telling their retirees that they must purchase on the exchange now and will not be provided retirement benefits. And the other company has indicated that there will be no family coverage, that the spouse and or children will have to buy through the exchange, and the company will only cover the employee. So we think that this is a hearken of things to come. Some of the local small businesses have started to cut individuals to less than 30 hours a week, other activities that will make them not have to purchase on the exchange, or contribute to their employees on the exchange. So there may be actually more uninsured than there are right now as a result of this shifting in the marketplace. So healthcare delivery system reform is a really large part of Maryland's reform. And just like we have the Medicaid or the Medicare waiver for hospitals, the hospital rate setting system, and the HSCRC, which is in place in Maryland only and is not a national phenomenon, so too the state of Maryland has decided to implement healthcare reform in a very unique way and to take advantage of all the opportunities that this revamping of the system provides. So they submitted and were awarded a CMS Innovations Grant. And this integration process is an effort to have all the alignment between the payer, the provider, the patient, the health departments. It is really a very aggressive plan, and it takes a lot of vision and tenacity to have conceived of it and then to implement it. But they are moving ahead, and it's based on 4 pillars: primary care, community health, strategic use of data, and workforce development. And the focus truly is on the payer community at this point. The payer community is seen as the hub of a lot of the changes that are going to come down the pike. They have begun payer and provider alignment. They've established what they would like their outcome goals to be. They will be holding stakeholder meetings to get provider input, consumer input. They're developing a governance structure for this community integrated medical home. And the plan, and probably in this coming session in Annapolis, you will see legislation to create a public utility for health care. One of the things that impacts the provider community and a healthcare setter that accepts a lot of uninsured individuals is the criteria for practice inclusion. And there are many criteria that are being considered right at this minute, and what that means is that not everyone who's practicing currently will be allowed into the system based on the criterion, and hopefully it will be a slow and gradual process because of the primary care shortage that exists right now. To actually curtail the participation of primary care providers seems a little counterintuitive, so we have to be really cautious in implementing this. Of course, quality metrics are very important. They're a big piece of this innovations grant, analytics, and shared savings. So the local health improvement councils are one way, and they were begun about a year ago, a little more than that, and they were all tied to CDC's Healthy People 2020 goals, and they were all brought down to the state level so that each jurisdiction could pick, based on its history and its population, what of those 39 categories they wish to focus on. All the health department leaders, the commissioners, and the health officers called together a lot of stakeholders. There were proprietary pharmacies in the room, public companies, various state agencies. Everyone really was pulled together in these local health improvement coalition meetings to decide on the top priorities, and then to decide on how each individual entity would contribute to the solution in some of these very persistent problems. The use of hot spotting for high utilizers is something that will be of much use to the local health departments, the health improvement councils, and to the state in implementing this new form of delivery reform. And those are the listing of the 6 primary areas of focus. CRISP is the data system that has been underway for several years now, and it now pushes out alerts whenever one of our patients shows up in an emergency room or is admitted into the hospital. So finally, we have access to some very rich information and use it in our planning, our community-based interventions, and it will be a tool for everyone in the system at this point. The all-payer claims database is now used mostly by the hospitals and private insurers, but they will add a measure to this through CRISP that there will be provider measurement on cost and quality and clinical decision making. And you can imagine what effect that has on providers, on provider behavior. This is a photograph of what some of that hot spotting looks like, where they have very high utilizers in the red area, people that are frequent flyers, as they're called, some with more than 200 visits to the emergency room in 1 year. Right now, CRISP has over 5 million people in it, and Maryland only has 5.9 million people in the state, so we're pretty much at 100% or almost there. And this shows you what other kinds of data that are in CRISP at this point, the hospitals, the labs. This slide talks about the Master Patient Index. So the developers at CRISP are working on a way to assign a patient identifier to every one of us, so that whether or not we're in Medicaid or we switch back and forth between Care First and another commercial carrier, or we're getting dental services or mental health services out of the standalone system, they will be able to track us through this common identifier, and all of our utilization will be able to be pulled up on a patient-specific level. And they're using 4-digit dash after the zip codes for this GIS mapping software process. This defines a little bit more the expansion of the database under this new delivery reform program, and how neighborhoods with high utilization levels will be identified and then resources deployed in the form of community health workers. So the Healthcare Practitioner Performance Measurement Project is a part of this project, and you can see what the purpose is as stated by our state. And I underline the better informed practitioner selection. So you see there again that there's an emphasis on provider behavior and how it will allow you to stay in the system, or there will be some other, maybe perhaps remediation or other aspects to allowing providers to practice in the system. And the promotion of performance improvement, transparency, for sure, cost and quality, all laudable goals. This next slide talks about how they intend to get there. They've identified the National Quality Forum as the place from which the measures will be picked, and how the reports will be made available once they're in aggregate form. This is an interesting proposed regulation that is in front of the legislature right now. The comment period has closed. It closed on September the 9th. And this allows the the medical assistance program to conduct on-site visits of any and all provider locations, and they are unannounced. So this is a hearken of things to come, and we're not sure if this is going to make it through the regulatory process. We know there were a lot of comments on this. So the safety net system. These are the federally qualified health centers that exist around the country. And I'm going to assume that you all understand the regulatory environment and the creation of the FQHC as an institution and the regulations that it must abide by. There are several other types of entities considered safety net, and the state understands that we serve a significant part of Medicaid and the uninsured. So 671,000 in 2012 alone. And this gets us to Peoples. And Peoples started as a free clinic. It started in the 60s. And if any of you went to the Independent Film Festival this year, there was a documentary called Hit and Stay. And it had a great description of that era of what was happening during the late 60s and early 70s. And People's Free Medical Clinic was founded by many militant groups, the Black Panthers, the Gray Panthers, the Women's Liberation Movement, the Students for Democratic Society. There were many entities together, and they raised money for the Berrigan Brothers and the Catonsville Nine. And the funds that were left over from defending that group were used to start People's Free Medical Clinic as a means to remember that period. So we're still in that building. It's been sandbagged during the riots of the late 60s. We've had it renovated. We've raised more than $1 million to improve the facility, so it's a little juxtaposed from those days out on the sidewalk taking blood pressures. Right now we offer all the primary care services, including dental and pharmacy, mental health and addictions work, and we have locations. We sort of cut a line down the center of the state between North Baltimore City and North Anne Arundel County. And we're Joint Commission accredited in both primary care and behavioral health. Our patient mix ends up with about 51% of our visits being non-billable services because of either the uninsured with no means to pay or services like case management, which are not billable in any system. Our patient demographics are predominantly adults, predominantly female, a good mix ethnically, and our health conditions are what you would think: diabetes, hypertension, asthma, co-occurring substance misuse and mental health, cardiovascular disease, and HIV/AIDS. So, primary care transitions. This is how we have been reacting, responding, and supported to be prepared for all of these things that I've been describing. We were completely funded by the federal government to implement electronic medical records, and that's quite a cultural shift in any setting, private practice, hospital, whatever the setting. So we were well supported through that, and we are completely electronic at this point. We've also added a chronic disease management software so that it's not just individual patient files. We're actually able to do population management by the site level, by the provider level, by the disease topic. It's very rich data, and it helps us in our planning. We have applied for patient-centered medical home. We were supported in that application. We were just awarded the certified application counselor funding so that we will be an access point. So the standards that are being proposed and are in place have created 3 agendas in the exam room for our providers. There's the patient's agenda, the provider's agenda, and the regulator's agenda. And that makes for a very interesting visit that is supposed to occur within 15 minutes for each patient. So changing provider behavior is a major initiative, and it's being pushed by DHHS, CMS, Medicare, HEDIS targets in Medicaid. Kaiser has begun some efforts in prescription reform, and our trade association has also been involved in helping the health centers navigate through the system. The Delmarva project, this is the first time Delmarva has been funded to do a service project. They have picked Medicare, and they have selected emergency room prevention as their area of focus. Kaiser has funded the All-Phase program. The Work-Life program at Hopkins has funded our integrated care model. Kaiser's program requires that the providers who meet with patients who meet certain circumstances prescribe these 3 drugs for patients who are hypertensive or diabetic, and they participate in a longitudinal study. And the study is both based on clinical outcomes and on provider willingness to participate. The Health Enterprise Zone is a new creation by the Lieutenant Governor, and we are on the board of that zone, and we participate as a service provider in that area. They too are following the same patient empowerment model, community health worker model. Everything that is new coming out of this state is driving individuals, communities, and institutions toward this one model. Peoples has taken an approach with a model that's worked nationally in other community health centers, and that is the combination of a behaviorist with the medical visit. And there is a lot of literature on this. There is about 2-year track record with several of the health centers that have been pioneers, and the first study issued by Care First shows that there is compared to the rest of the state, individuals enrolled in this program utilize emergency room visits 32% of the rest of the state's population. So it's having a tremendous impact. Even though the primary care visits have gone up, all the other utilization has gone down. And the straight line that you see across the middle of that screen is where all the other utilization is for the other providers. CRISP now informs our care management. We get alerts every day for patients of ours that are in the hospital or in the emergency room. So our focus has shifted on, rather than retrospective care management, we're trying to get in front of it. We now are in line to secure certification for our application counselors. We've not been trained yet, but the state has us in queue to be certified so that we can access those databases that I was describing earlier. Our clinical outcomes are somewhat disadvantaged because of our patient population, and because there's no claims data repository for the uninsured, there's no way for the state to understand how impacted we are by adverse selection by uninsured individuals. So this is a wait and see for us to understand how having individuals who use bodegas for their groceries or soup kitchens or places where they have really no access to fresh food, fruits and vegetables, or cannot afford their medications, how that's going to impact the evaluation of the provider as managing their patient population. On the upside, the Medicaid expansion will mean better reimbursement for all the health centers, and it will help support some things that we can recycle into more access or maybe greater assistance to our patients. And we've been declared an essential community provider. So the qualified health plans must contract with us. So the federal government has built in some protections. So that is our plan for the near term, is to obtain these contracts with all of those entities that we know are approved. Our focus for financial stability must shift to payers because the giving community, the donor community, believes to some extent that the problem of healthcare access has been solved. So many foundations and corporations are much less inclined to continue giving to healthcare as one of their areas. And that concludes my presentation. Thank you very much.
Thank you, Pat. And we're going to hold questions till after both speakers. So we're just going to get our next speaker, Amy Lynn, set up.
Good afternoon. Thank you guys so much for being here and for having me. We're really excited to be here to speak about the Affordable Care Act and how it affects young adults. My name is Amy Lynn. I'm the Deputy Policy and Organizing Director at Young Invincibles. And just to give you a little bit of background on Young Invincibles, we started in 2009 during the healthcare debate. We're a national nonprofit based in Washington, D.C., and the founders of the organization were Georgetown law students at the time. And this was right around the time when the Affordable Care Act was being debated as a bill at the time. And what the founders realized or noticed was that there were a lot of different people at the table when it came to speaking about this bill, but not many from the young adult population. So they started a website that really was just asking people to share their stories, asking young adults to talk about how healthcare and health has played a part in their lives. And really just got an overwhelming response, much more, I think, than what they were expecting, and really saw a whole lot of interest when it came to this population and this generation being very interested and invested in health and health care. And so the organization started from there, and we're called Young Invincibles. It's a play on a health insurance term. Obviously, a lot of health insurance companies had said before that young adults didn't need health insurance or felt like they were invincible. And part of what we're saying is that actually that's not true. There's a lot that young people can use and want when it comes to health care. So we now actually work on 3 different issues. We still work a lot on healthcare and implementation. We work on higher education and the cost of college and paying it back and student debt. And then we work on unemployment and jobs. And this is last spring, I actually led our bus tour, this is our bus. We went to 20 different states, 43 cities in the course of about 2.5 months. And we talked to young adults all over the country about those 3 topics that I just mentioned, and got a sense of where young people were coming from when it came to these topics. And this is a healthcare rally that we attended at a clinic in Cleveland, Ohio, and it was about supporting the Affordable Care Act. And so my role in Young Invincibles is to bridge the organizing and the policy side, where we look a lot at the regulations and at what's coming out when it comes to guidance on the ACA, and then we talk quite a bit to young adults on the ground and a lot of different groups and organizations who are very busy and working hard on implementation. So part of what I did for this presentation was I assumed that everyone in the audience had a very sophisticated knowledge of the ACA and all the policy bits behind it. So I'm not going to go through those very specifically, but we're going to talk quite a bit about outreach and what it means to talk to young adults in this 18 to 34 population about health insurance, especially since some of the people in this group have either never had health insurance or have gone uninsured for quite some time as a result of just not being able to afford it. When we look at who we're talking about here, this is a study from the University of California, San Francisco, where we're talking about projected numbers of young adults. And you can see the population that we're talking about in this case is 18 to 24, and it's growing quite a bit. And it's projected to get larger and larger in terms of numbers. And it looks like about 10% of the total population. And if you consider the fact that the uninsurance rate for young adults is much higher than the rate overall for people in the United States, then it becomes very clear that this group is very critical to making sure that the Affordable Care Act succeeds, and then also these are the individuals that we should be focusing on when it comes to figuring out who needs to get health insurance and who needs to get signed up. A further problem there is that this is actually the population that has a very big awareness gap. So quite a few individuals don't know about the new options, and then even more of those who could qualify for Medicaid under expansion also don't know about the options for insurance. So Young Invincibles is very committed to working on this fall, next spring, and then all throughout, and then next year too for open enrollment when it comes to making sure that we're getting the word out to our constituents and then the people we serve about this law. So when we do these presentations, generally we do a lot of details about what parts of the ACA affect young adults. But just to give you guys the highlights, because again, we figured that a lot of people were very familiar with the law, we talked quite a bit about the dependent coverage provision because this came into play pretty much right after the law was signed. If you have a parent who has insurance that covers dependents, now you can stay covered up to 26. And we saw a lot of young people take advantage of this. It was something like 3 million young adults signed up for this. And this was a really big deal because, so back when I graduated from college, it was like the day after I graduated, I got kicked off my parents' health insurance. And that's very normal. There's a lot of drop off right around that time, or sometimes when you turn 19. And so we're seeing large percentages of uninsured young people right around that age, just as they're finishing. And so this particular provision was pretty exciting to us. We worked really hard to get this passed. And so that's one of the first things that we talk about when we talk to young adults. The other parts that we always emphasize are women's health benefits. The well woman visits are covered, preventive care for screenings. This is particularly important for women within this 18 to 34 age group because of that period of time being the reproductive years for women. And then also just the fact that it's part of the preventive care now, which is a big deal. Student plans are something else that we also talk quite a bit about, especially when we're on college campuses. Basically, a lot of college students we talked to on the bus tour had mentioned that in the past, if they'd had a student health plan, A, they often weren't sure what was covered, and B, weren't particularly knowledgeable about what their money was going towards when they were buying these plans. And so one of the good things about the Affordable Care Act is that it now includes student health plans as part of under all the regulations. So student health plans have to meet all of the same regulations that all the rest of the health care plans that are being sold post-2014. And that includes spending a certain amount of money on the students and the person who has the plan, and then also offering preventive care without any copays. Medicaid is the other piece too, because the new populations that we're talking about are often the single childless adults, the people who could qualify for Medicaid if they live in a state that expands. So we always talk quite a bit about that. And then really a lot of it is just going over a marketplace and what that means, what it means to be able to buy a plan that covers essential health benefits, and what it means to be able to get a tax credit to pay for that plan. And then the last thing we always make sure we talk about is the individual mandate, as it is obviously a critical part of this law. So we're talking a little bit about this population and outreach and what it means to try to talk to the individuals. We have a few different segments of the population that we always like to be aware of and keep in mind. So we have those who feel like health insurance might be unnecessary and uninterested, and we know that quite a few of them use social media and that they actually do have some factors when it comes to motivating them. And then we know also that these individuals will often listen to their family members or to their friends or to medical professionals. If we talk about the reluctant but reachable population, what we know is that quite a few of them have smartphones and that they're also very motivated by financial security and getting a reliable plan. And then they would also listen to medical professionals, someone else who looks like them or who is in their same situation, or perhaps the state health agency. And then in the last population, if we talk about who is insured but potentially at risk, again, a high percentage of these individuals will use the internet several times a week, and then they're also motivated quite a bit by financial security, having a good plan, and will listen to family members, doctors, people like them. So we keep a lot of this in mind when we're doing our outreach, when we think about who's our target population. And because this generation is so diverse, because there are a lot of different things going on in that 18 to 34 age, when you're 18, you're very different than when you're 34. And so we have to be very careful when we talk to this population to make sure we're using messages that resonate with them and that really obviously would help them motivate to get health insurance and understand the benefits of getting health insurance. So when we look at a lot of the research out there that's been done on messaging, and this is from CMS and Enroll America, and then also I think a group in California and Colorado as well, we want to make sure that when we talk about health insurance to young adults, we're saying, using these messages that resonate with them. And so one of the top line messages that has tested as being very effective is the fact that you can see all of this information, your premium, how much it's going to cost you in one place before you decide to enroll. And that seems to be just very, it sort of resonates with people. When we think about the fact that all three of these groups were motivated by financial security, that makes a lot of sense. When we talk about financial messages to motivate risk takers, we talk quite a bit about how getting covered will save you money and the longer term insurance, or the insurance that you're guarding against the risk that you could get sick and that would end up costing you more in the long run. So buying insurance will actually save you money. And that would help you with your financial security. And then we talk about the individual mandate a lot too. It is the law. This is something that is important for people to follow, and that as of January 1st, 2014, it will be the law to have health insurance. some more research. Some of the terms that we avoid include exchange, which is a little bit complicated because a lot of the states obviously have named their exchanges exchange. But we try to say marketplace. HHS has also issued a lot of CMS came out with a lot of research about this. Exchange doesn't seem to resonate with people when it comes to health insurance, so we say marketplace as often as possible. We try not to use only messages that include your family. There are quite a few people in the 18 to 34 category who have families, but then there are also quite a few who would qualify for Medicaid and are single and childless and also just may be able to get a pretty big tax credit. And so we don't want those individuals who had previously probably not been able to qualify for Medicaid because they hadn't had dependents to feel like this doesn't apply to them. So we say individuals a lot. The last thing we try not to say is financial assistance is available. People don't seem to identify with that, and they don't think that that applies to them. It's usually something that's for someone else, not for them. So we talk a lot about tax credits that could make your premium for your plan low cost or potentially free. So when we're talking about outreach to young adults, we definitely always want to emphasize the importance of continuing to do traditional outreach methods. These are the methods that we know have worked in the past, that a lot of organizations, student groups, community health centers use all the time. The first would be tabling. So that really is just setting up a table outside, talking to people as they walk by, or even just standing with a clipboard in the middle of the sidewalk and stopping people as they walk by. A health fair is another example of a more structured type of tabling. And that is actually very effective. And Young Invincibles does this quite a bit. We go to a lot of health fairs. We work with a lot of different groups that are putting on events that involve just chatting with people when they walk by, giving them information, giving them brochures or material so that they could take them and go back and read them and then also know where to go. We also do a lot of group presentations. We have actually gone around the country and conducted 50 trainings with a lot of different state groups and community organizations about the ACA. And our plan is to do 75 more in the next 6 months. And so we do this, routinely, where we get a group of people, not unlike this, into the room and talk to the individuals who are present about the importance of the ACA and what people need to know. And then a lot of just information giving, and then also encouraging people to go back to their organizations and share the information too. Hosting events is a little bit more on the maybe fun sort of interactive side, where we might screen a movie about healthcare or health insurance and then invite members of the public to come and see the movie, and then also potentially have a panel afterwards or something like that. So we basically just want to make sure that we're still emphasizing the traditional means of outreach, because these are really important, and it's important to find people where they are. So in the case of young adults, I think finding them where they are, meeting them where they are is incredibly important. And a lot of times it means going to a place where young adults are likely to be. And that varies very much depending on where you are and what community you're in. One of the ways too that that is pretty effective is to collect people's information and then follow up with them later. Because a lot of times they're busy, or they may not have a chance to stop and talk to you extensively about something, but they are interested. And so having a sign-up sheet, which is something very basic, can be incredibly helpful. Thinking a lot about options of where people could be that's outside the box, where young parents may be, if they have children, where mothers might be is also really important. And then we do this a lot. We work through a lot of the community groups because we're national and we're based in DC. We have an office in Los Angeles and then a couple of others that we're in the process of opening. The trusted sources that we talked about earlier when it comes to the segments of the population and who they listen to, those are their doctors, those are their community leaders, those are people who lead their churches. That's who we need to be speaking with and making sure they have the information and can also send the message on. So it's really important to find people who are trusted by the individuals who we're trying to reach. So Young Invincibles works quite a bit on social media and online ways to do outreach. So we talked about traditional earlier, which means standing there and talking to individuals one-on-one, or being in a group setting and talking to them this way. There's a whole lot that we do online that's actually really effective and particularly important, I think, to emphasize with the young adult population. So the first thing we always say is that if you have a website that you're trying to get people to, one of the most important things you can do is make it accessible on your smartphone. So I don't know how many of you guys have ever opened a website on your phone and you can't look at it and it's tiny and it's awful and then you just close it. You're like, I'm done, I don't want to read this. That's basically the reason why it's really important to make sure if you're trying to get people to look at your website that they can read it on their smartphone. We know the population who we're trying to reach uses smartphones at a much higher rate than the general population, and that a lot of individuals actually use their smartphones as their primary source of internet. So it's really important to consider that. The other piece that we always emphasize is text message services. I open all of my text messages, but my emails, I have a lot of unread messages, and they just don't necessarily catch my attention anymore. So we've seen text message campaigns work with a lot of success because people read their texts. They're just short enough and they pop up on your phone, they notify you, and generally just have a really, really high rate of being opened. So that's another way too that we talk about, if there's a community group or a group of individuals who are trying to get a lot of information across or a message across to people, text message services can be very helpful. We're going to talk more specifically about social media and then the mobile app and mobile applications. So first, social media is actually an incredibly effective outreach tool. We always want to emphasize this too, because I think sometimes when we're working in the health space, there is a tendency to think of Facebook and Twitter as sort of more on the social networking side and less on the information sharing side. But what we want to make sure we're emphasizing is that there's a huge opportunity here to give a lot of information in a place where people are. This is where young people are. So 1 in 5 Americans have reported using Facebook or social media to get health information. Half of the Facebook users are in our age group that we're looking at. And we saw research that said that young adults actually really value reviews that they get through social media. And you guys might have seen this or done this yourselves, where you write on Facebook or see a friend who says, hey, does anybody know any good restaurants in the area? Let me know. And that's basically a way of surveying all of your friends, people who you trust and who, whose opinion you trust, and asking them for information. And this is the same too when it comes to a lot of different things, including healthcare. So there's a big opportunity there that we want to make sure people are aware about and are considering using and really using for their information campaigns. When we're talking about online interaction, it's important to think about the different ways to engage people effectively. So the first thing is always to listen. And so that means, if I'm a community organization and I want to start a healthcare campaign where I'm trying to give information out about health and about the Affordable Care Act and what young people need to know, I think the first thing that's really important is to make sure we understand or hear what's already going on in this community that I'm trying to reach. So setting up some type of Google alert so you're aware of what's being said in the news. So you can do something where you put in maybe the city that you live in and then also certain keywords that you're looking for and trying to make sure you are hearing what's happening. And the next step is to engage. So asking people questions over social media and then responding to them in real time, posting things that are interesting and fun and informative on your Facebook page or on Twitter. And then the last part is really, once you've engaged people and kind of started to touch base with them, it's building that relationship. So finding people who have a lot of followers or who are very well regarded and having those influencers help with your message, sharing helpful information, having a conversation over a social media site is also very good. And then recognizing those who have done good work and giving them shout outs and recognition for sharing good information or for doing something good. We talk a lot about, this is just an example of one of the social media platforms that we can encourage a lot of the community groups to use. Many of you, I'm sure, use Twitter, and so we won't go through all the specifics, but this is just one example of sort of the more detailed information that we work on giving community groups when it comes to talking to young adults. So this is an example of a tweet that we put out when we were talking about health insurance options in college. Something else that we've done quite a bit is a Twitter chat, and this is basically a really great way to engage with people who you wouldn't be able to talk to in person. So we did this for the Los Angeles mayoral race a few months ago, and we basically had a Twitter chat with the candidates who were running for mayor. And it was really exciting because these are individuals who we otherwise would not have been able to talk to, but because we were doing it over Twitter, we were able to touch base with them and then get them to engage with us and then also just had a lot of other individuals asking questions and engaging on that too. And in this case, what we did was, just set a specific time, said everybody was going to be online to do this, and they should send their questions over with a hashtag, and they answered them in real time. One of the things we also work a lot on too, we put out a lot of Facebook memes. So this is right after the Supreme Court decision was handed down, and we basically just shared this image, and we're talking about our support of the Affordable Care Act. And at that time, I think Young Invincibles had about 12,000 followers, but this particular Facebook post got shared 205,000 times. So that was a lot of people that we were able to engage with very quickly in a short amount of time. It was over the course of one day. And these are people who later came and liked our page, and so there were additional people who we were able to get to look at what we were talking about and to engage with us. And in the future, when we shared or posted more information, they were seeing it. That was part of our audience now. And so that was really the value, I think, in being able to generate something like this that would get a lot of attention in a short period of time, is that you can get those who are interested to engage with you, and then the task is to follow up with them and to continue to give information that's useful to those individuals. I talked a little bit about mobile apps. This is actually a mobile app that Young Invincibles has developed called Healthcare. It's called Your Healthcare Finder, but it comes up under Healthcare USA in the Google Play Store and the Apple Store. So this is basically, we'd been testing this in its beta version, but it was designed so that you could put in your zip code or where you are, and you could find a doctor. And then you can also find information and frequently asked questions about the ACA. And it's very basic and easy to read format, so you're on your smartphone and you can easily read it. And it also would define and just give sort of common health insurance terms. So for somebody who may not be very familiar with what a deductible is or an out-of-pocket cost is or co-insurance, that's all within there too. The good thing about the mobile app is that people download it and then they just have it on their phones, and then when the time comes for them to need it or to use it, it's there. And then we can also use that function to send text messages when we get closer and closer to October 1st. And these are push notifications that are like, hey, open enrollment's about to start. Here's the website for where you should go to get health insurance. And we can give them that specific information depending on where they are. So our big campaign this fall and next spring is called Healthy Young America. And our website's there, health.younginvincibles.org. And as I'd mentioned before, we're doing more trainings and actually enrollment events as well. So in the next 6 months, we'll probably be doing at least another 70, either trainings or enrollment events. We are working with 4 different states under the Navigator entities as a sub-grant and part of the consortium of individual or organizations that are working to be navigators. So that includes New York, Washington, D.C., Virginia, and then Arkansas. And so we're obviously going to be doing quite a bit there on getting people enrolled in health insurance. We're still working a lot on our mobile app and making it better and putting out a new version of it that'll, I think, come in November. And on our website, we have a lot of different information out there, a state-by-state fact sheet for who's uninsured and young in every state. And it's broken down by city. And so that can be really interesting too. We have a lot of frequently asked questions. People ask us questions all the time about the ACA, and that's on the consumer and on the advocate side. So if you're an organization that's working on something, or if you are an individual and you have questions, we have all the different FAQs that have come through. And we are about to launch our toolkit, which is a built-out version of all of the information that I shared earlier on Facebook and on Twitter. And so it's individual pieces that are designed to help groups and student leaders or just community leaders put together different types of outreach campaigns, whether they want to spend more time doing it on Facebook or if they would rather do it traditionally or a combination of the two. The toolkit's really helpful for that. So that's also coming on the website. We have a few parts of it already up, and then we're putting up a few more this week. And we've done quite a few webinars in the past too. We did one with HRSA last week and some with community colleges too. And then we're going to have more coming very soon. One of the last things too that we'd worked with HHS quite closely on is a big video contest. And this is really HHS and Young Invincibles working together to target, again, this young adult population and to try to engage young adults in a creative and sort of innovative way. And so this is basically we're asking young people to submit their videos of answering these three themes. So either you're not invincible and why, to perform a song, or to do some type of animation. And I think we're announcing prizes soon. There's several rounds of prizes, and there's a lot of voting going on too. We're just really excited about this because we're seeing a lot of people engage and get really excited about putting together this information. Again, sort of dispelling the myth that young adults don't care about health insurance or aren't concerned about their health. And so stay tuned for that. That's sort of ongoing, and voting starts, I think, early next month. So the last few things too that we always encourage people to do is to, first get more information about what's going on, whether it's your state marketplace, which is obviously coming, or healthcare.gov, which is in the process of, there's quite a bit of information already on there, and they update it all the time. Also, when we, give the presentation and talk to people, we ask them to spread the word, and there are a lot of different ways to do that. And that's part of the emphasis too for us is, getting people where they are and then recognizing what they're capable and able to do. So if it's something as intense as, say, volunteering, or maybe just sharing on Facebook some information that you have, all of it's really helpful and I think really important when it comes to making sure this law is implemented and the word gets out. And then also just sharing when there are success stories. So if people are successfully signing up for health insurance after October 1st and, are able to go onto their state's marketplace and fill out the form and easily, know whether or not they qualify and what they might qualify for. Sharing that once it's happened, how easy it was or how the experience was. I think that can be very effective. And then of course, we always want to share the information we have on open enrollment. This is what we do have as far as the hotline and the website for the federal marketplaces. And then our last ask is always follow us on Twitter and then like us on Facebook. So I will turn it back over to Janice so then we can take questions.
Again, up on the screen, you'll see the email address for people to send in questions, and we'll also get questions from our live audience. For people in the live audience, today we don't have someone passing the microphone, but it won't bite you, and so if you just come right up here and speak into the microphone, and the reason for that is so that your questions can be heard by the online audience. So let me just say, for my part, I thought this was a great set of presentations. And I really noted the symmetry between the People's Free Medical Clinic in the 60s and the work that the Young Invincibles are doing right now. So that was exciting. So let me start out and see if there's any questions in the live audience. Not yet? Okay. Oh, sure, come on up. And you just need to make sure that the green light is on.
So my question, I think, is more for the Young Invincibles. I have been doing some outreach work here in Baltimore City, in Baltimore County, and talking to some people at community colleges. A question that comes up for younger people is if they are listed, if they are claimed as a dependent by their parents, but their parents do not have health insurance, are they going to be able to apply as an individual through the marketplace, or would their parents have to sort of do that for them?
Yeah, that's actually a very good question. So we work a lot with the Center on Budget and Policy Priorities, and they have put out quite a few different really helpful webinars on how families are going to be able to decide what types of plans they can apply for, and how that is going to look as far as how many individuals are applying together as a family, or if they want to do it separately. So I think the most general basic answer is that the student, the young adult, can decide if they want to try to apply for their own plan, or if they want to do it with one of their parents or both, or other family members. And that's going to affect, obviously, the income levels of the individuals and also who may qualify for what different types of benefits, and also what state you live in. So if you live in a state where you could qualify for Medicaid, and they are expanding Medicaid, then I think it really is going to end up being like an individual's and family choice. And so you might have one parent who has a health insurance through an employer or in another way, and then the parent and the child can apply together in that way. It is a pretty complicated formula to figure out how that's going to look, and we have a lot of the, again, the Center on Budget has kind of put out a lot of information about that, but we're going to look more closely to, especially as we're working on the Navigator side, to help people get signed up and see, you know, what's the best choice for them. But that, I think that really comes down to the individual and then also the family.
Pat, do you have anything to add to that?
No, I think she handled that
Okay.
very well. I do know that in Maryland, we've had the under 26 covered for several years now. It's not a new phenomenon, and sometimes it's better to look at the under 26-year-olds' income separately, because they may qualify for Medicaid on their own, which would be a much better benefit package.
This is kind of a good segue to a question for you, Pat. You mentioned that people will be able to apply for insurance at community health centers. And will the centers have a dedicated navigator? And how long do you anticipate these application sessions will take?
Each community health center has been given a certain number of individuals, and they will be dedicated to that function. They will not be multi-purpose to do other work inside of the health center. We have, many of the health centers have an appointment schedule already in mind, so that people are not waiting to be served. And the application process right now, because it's paper-based, takes about an hour. And I would say that we're looking at a half an hour to 45-minute duration of this kind of encounter, because so much will be available electronically.
Okay. There's a question here primarily for Amy. What do you think about a different kind of product for young people with high deductibles, or with excellent coverage for reproductive health, pregnancy and injury care, but not as much coverage for non-episodic care, for chronic care?
So one of the plans that we know is going to be sold on the marketplace are catastrophic plans, which are targeted at younger and healthier individuals, or those who may not be able to find a plan that's less than 8% of their income. So you can't buy a catastrophic plan unless you're under 30, or if you can't find a plan that's less than 8% of your income. And at Young Invincibles, we talk a lot about the catastrophic plan and how we want to make sure that young adults who may be considering it understand fully what it covers and what the high deductible means. And so if I'm shopping on the marketplace and I see all the different options, and I could get a catastrophic plan, a bronze, a silver, a gold, or a platinum plan, but I'm looking at the premium amount and the catastrophic plan is lower, we just want to make sure that when young people are shopping for those plans, that they understand that that catastrophic plan deductible may be $6,000, which is how much they'd have to pay before the rest of the health insurance kicks in. And so the other piece of that is also that the catastrophic plans, you can't use a tax credit to pay for that. And so we just want to make sure people have all the information they need to make the right decision for themselves. And if it's, the catastrophic plan is the right choice for an individual, then that's great. And some people are going to make that decision based on what they know they need in terms of health coverage. For the benefits that may include more on maternal or reproductive care, we know that the plans that are sold on the marketplace have to have 10 essential health benefits, and those benefits have to offer a minimum level of coverage, and that includes preventive care and then also maternal care. And so I think the decision on what kind of insurance to buy is absolutely an individual choice, and people can look at the different options and decide what's right for them and for their own lives and for their families. But what we are happy about is that the essential health benefits do offer this level of coverage that is important for everybody to have. And so beyond that, I think making sure people have the right information to make the best decisions for themselves is probably the most important thing that we pay attention to.
Okay, thank you. Can I ask our presenters, people are having trouble hearing online. If you can speak more into the microphone and be sure your mics are on. Thank you. I have a couple of related questions for you, Pat. One is, what impact, if any, do you think the ACA will have on the mental health and use of mental health services of the population that your center serves? And kind of a follow-up question is, when will the mental health and substance abuse standalone coverage be available, and where is more information available?
To the latter point, the state of Maryland is still working diligently to collapse the Mental Hygiene Administration and the Alcohol and Drug Abuse Administration. And you can imagine that when you're combining two large state agencies, that it's a very long and complicated process. So I believe they are not anticipating it to be available until late 2014.
Okay.
And that would be when to start watching for results from this consolidation. Regarding behavioral health access, there is a very large gap, and there's a lot of stigmatizing that happens with people seeking care. So the no wrong door approach really is very effective in a health center that offers many services. No one knows if you're entering the building for pregnancy services or a dental visit or a mental health visit. So the health centers that do offer mental health have a much, I guess, more robust population who will seek care. They will sometimes pair visits with their medical provider and their behavioral health provider or their substance abuse provider. So it's a very effective model.
Okay. Any questions from the live audience? Okay, we'll move on to some more questions from online then. This is for Pat also. Are you concerned that the volume of new patients will be too much for a community health center like yours to be able to deal with? And what have you done to try to anticipate and work with this?
Yes, the answer to that is yes. We are nervous because there is pent-up demand, and when a provider sees a new patient, it always takes longer because there's the history taking and the visit is just protracted. So to imagine that all of your new patients are coming in the door and will bottleneck a system where there's already compromised access to primary care, it's very concerning. So we have started to look at capacity expansion by extenders. And the behaviors model, I would really recommend people look at the Cherokee, Tennessee model. The New Mexico and West Virginia groups have also advanced this model. It's very effective clinically, and it has the effect of expanding provider capacity because it peels off a portion of the visit and allows a behaviorist to manage pieces of the social determinants of health aspect of the visit, which oftentimes complicate the medical interaction. So the other piece of this is through the Delmarva project, we have been permitted by CMS to utilize clinical pharmacists to do much of the intake and evaluative work. They do not make a diagnosis, nor do they treat, but they are able to again, act as a provider extender and do quite a bit of work. And pharmacists are in a greater supply than our primary care physicians in particular. So there are other ways to accomplish and prepare for this, and I think all the health centers are handling it a little bit differently. We've had some great luck with these models that we're trying.
Okay, here's a question online for Amy. The media talks about Americans being unhappy with the ACA. Have the Young Invincibles done anything to get the message to middle-aged people that there's a real benefit with their children being able to be on their policy till 26?
Yeah, so we actually work quite a bit with identifying young adults who'd be excited and willing to be spokespeople for the Affordable Care Act and also for their positive healthcare stories and experiences. So part of that means when we talk to young people who are excited about the law and the changes that are coming, or their ability to now get preventive care without a copay, or to be on their parents' plan until they're 26. When we find young adults who are really excited about that, and quite a few of them, the people we interact with express that support, then we ask them to be spokespeople to talk about why this law is really important to their lives and why and how it's affected their lives positively. In my experiences when we've been around the country and talking to people of all ages, we've heard a lot of supportive things from individuals who have children who can stay on their plan, or who can now access health care without being denied health insurance if they're under 19, or who just feel much more comfortable with the fact that there are more options now for their children. So we've had an overall very positive experience with a lot of people who are really supportive and who are really excited about the provisions that have already gone into place, and then the ones that are coming too.
Okay, thank you. If there's any questions from the live audience, you can just come up here anytime. We have more online questions. One question is about, Pat, you mentioned the local health improvement coalitions, and I know from your own experience in being part of one in Anne Arundel County, and you mentioned the high need patients with wraparound community services and community health involvement. And I wondered if you could speak a little bit more how this kind of process is going to embrace public health strategies for prevention.
Well, I can speak to Anne Arundel County's
Okay,
experience, and the two areas that they selected as their top areas are obesity and substance abuse. And each of those clinical categories have their own circle of social services and private sources of support. And the health commissioner was very instrumental in bringing together your traditional Weight Watchers and companies that you wouldn't think to be a part of a public health initiative. They engaged employer groups, walking trails. They really took a very creative approach to this. And in having this group combined for the first time, there was an ability to see that there was benefit even to high need patients, not just your normal circle of clientele. So there was quite a bit of synergy that resulted in new programs that have emerged, some with the companies donating services, some with a planning group together to plan certain either landscape activities for walking trails and community gardens. It's really been an interesting process for the obesity intervention, which of course for cardiovascular health and diabetes and hypertension, there's just a downstream benefit that will be remarkable. As for substance abuse, there was a similar effort. Anne Arundel County is very far ahead. They have a warm line. They have mobile units. They are very proactive with their substance abusing population. So that subgroup's focus was much more on outreach and engagement and identification. And they've been able to mobilize, again, private partners and entities that you wouldn't think would be a part of a public health initiative. And the reach, therefore, has been much greater than it would have been had we all been working in our silos as we normally do. So it's laid a very good foundation for whatever other chronic conditions that they are going to be taking on in the coming years.
Okay. Here's a new question. What kind of training are People's Community Health Center providers receiving related to the Affordable Care Act? And are providers receiving training specifically for youth? I'm not quite sure what that question, but the first question, what kinds of training are providers getting?
Well, first of all, we would love to partner with the Young Invincibles to develop a provider education program for youth engagement and youth treatment, whatever is on their strategic plan. We would be happy to do that. We've developed a group of our staff that are the Health Reform Task Force, and it's their job to stay on top of all of these new developments as they occur and to disseminate the information. We have a provider meeting once a month. It's really integrated into the fabric of our day-to-day operation so that it is somewhat continuous. And we do send or ask providers to attend outside training programs so that they can see that how the rest of the world in Maryland is responding to some of these new initiatives. Our trade association has some very good opportunities for provider training, and our providers have taken advantage of that as well. So they're very engaged, they're very interested. It's been a pretty routine process at this point.
I think from Young Invincible standpoint, we have done some trainings in the past with community health center professionals, and it's something that we would absolutely love to do more of and more systematically too. We work quite a bit with a lot of different individuals who have a lot of expertise working in the field and in the community, and what we try to do is add value when it comes to just considering the young adult population and where some of these people might be and how we can reach them. But we would absolutely, love to continue to partner and to do more systematic partnering with community health centers.
Okay, here's another question that just came in. If a new mother has Medicaid because she has a newborn baby, does the Medicaid also cover other health issues that are non-pregnancy or reproductive health related?
Do you want to take that first?
You probably have more expertise on this, Pat, than I do, but I think it depends on the state, and it depends on what the Medicaid program there will cover in terms of maternal health and where the child is covered. That's sort of the most basic info I have.
Specifically to the state of Maryland, there is a purple and white card, as it's called, as opposed to the red and white Medicaid card. And it is only for family planning services that includes any reproductive health services. And it extends to women who are in a different income level. And only the maternity-related or family planning-related services are covered for that individual. The child, of course, is covered for just about everything, but the mom is limited.
Okay. We have time for one more question. There's a class following us in this room, and we have one question from the live audience. You can just pick that up and turn it on.
Hi. My question is in regards to the provider training. Are providers required to undergo training? And if so, or if not, how do you plan to capture those providers who are not required to undergo training?
Required is sort of a strong word. It's a very collaborative group, and in holding provider meetings periodically, monthly, or more often at our health center, for example, our Ryan White program holds more regular meetings because of the impact on the HIV/AIDS community. They're willing and interested, and it hasn't been a matter of not being able to engage them. We have other methods to reach the providers that work in our health centers, electronic means and dinners, other more collegial ways to make sure that the information is getting out. The providers enjoy going to the outside conferences as well, so it really hasn't been an issue of not being able to get the message out.
Okay. Well, we're going to have to end at that, and I want to thank both Amy Lynn and Pat Cassatt for a really interesting presentation. And I want to remind everyone to put on your calendar October 16th, same time, same place, Grand Rounds, looking again at emergency disaster preparedness. So thank you very much.
Thank you.